We are about to start now. All right, I'm starting right now. Since we have very few people in the class and we spend so much time, I'll go ahead with the class. All right, I'll go ahead. So let's see. As you can see, the uh, as you can see this. I hope you can see me. Let me check from my slide because once I present, I won't be able to see you guys. Let me see. Can you hear me? Can you hear me? Can you see the slide? Can you see my pointer whenever I put it, please? Response from you. I'm starting right now. All right, so I'm going ahead. Good luck for those who have refused, to join. All right. Whatever their excuse, I'm waiting for their excuses. All right. At least I won't say we're all in the same Amazon, sir. I won't see no excuses acceptable. There's 33 people in this class. All right, so that you can see the rectum. All right. The rectum. And let's take a look little bit at the image you can see here, right? That's the rectum. Um, we'll look at it first in the location where we want to see the rectum, right? And then if you look very well or look very closely, what you can see, um, we've done our pelvic cavity, right? And then within the pelvic cavity, we are seeing some structures that are content of the pelvic cavity. All right, here you can see your pubic bone. All right, first off, let me remind you this is sagittal section taking, and then here the media view is being seen. All right, after the body is taken on the sagittal plane rather, and what you can see are the pubic, the bladder. All right, and as you can see, this is a female. All right, so you see the uterus in an anteverted position. All right, resting on the bladder within the content of the pelvic cavity, all right? And then you can see the vagina, which is also part of the, is also content of the pelvic. And I will treat this in the internal female genitalia, all right? Also seen are the ovary, okay? You can see the bowel, okay? You can see the bowel, okay? The rectum and the anus, ending in the anus, okay? These are all seen. Um, this rectum is a continuation of the large column or large bowel, which is also part of the bowel. All right, you have the small bowel and you have the large bowel. And the rectum is a continuation of the large bowel, as you can see. All right, and also if you take a look, if you clear look at this, you will see the vertebra. All right, and the vertebra you can see here is just the last lumbar vertebra, all right? And there's the intervertebral disc between the lumbar vertebra and the first sacral vertebra, all right? And then if we take a little bit, they count more from the first, you see the first sacral, second and third sacral vertebra. And then you have the fourth and fifth, all right? And this, you have the coccyx, all right? Um, Now, if you see the line that is taken to transect the level of the third sacral vertebra, you can see at the upper part, you see the rectum beginning at that level, all right? So we can clearly see that the rectum commences what at the level of the third sacral vertebra, all right? And we could also appreciate the curvature or the curves, all right? Or the concave appearance of this sacrum, all right? Of the sacrum, it has a concave appearance, all right? You can see it approximating, all right? Beautifully well, you can also appreciate the fact that the rectum take off will follow that posterior concavity, okay, of um the sacrum, all right? Beautiful. So that you can see. Also in this image, you can see the length of the rectum, which is 12 centimeter. It actually commences at the third sacral vertebra from the what? At the same level where the uh, sigmoid column ends. When you do your lecture on when you have your lecture on the abdomen, you will eventually have to look at the you look at this. You have to know more about this. Uh, there's this other part of the bowel. All right. Now, the word rectum is from a Latin uh, language or Latin origin, and what it means, what the rectum means, is straight, straight. That is rectus, straight. All right, and you can appreciate that with that of mama, from that of monkeys. Okay, they have straight rectum, but that's not the case of him of we, as you can see. We said first it follows the posterior concavity of the what sacrum, and as seen from the external view, we could appreciate the fact that the rectum has shows three lateral curves, or we can say it has a three lateral flexure, and are most prominent when the bowel will be most prominent in a distended bowel. All right, will be most prominent in a distended bowel. And oh, sorry, we'll use the word bowel. Now, this curvature or the curves are, as you can see from the slide. Okay, we can see the um, we can appreciate this one up, this two. But beautifully well, the funny thing is you cannot see from this image that is being presented to you, you won't be able to see the external. What we're seeing is the inside of, okay, inside. So from the outside, we have two upper right, and two upper flexure curves towards the right, and then the middle we curve towards what? The left. We curve towards the left. Now, the lowest part of this middle curves appears with slightly more dilated, and we refer it to as what? The rectal ampulla. All right, this part, the rectal ampulla. All right. Also, from this, as you can clearly see, all right, as you can clearly see from this uh, image here, as you can clearly see, there also from the inside, when seen from the outside, you will see the corresponding crescent shaped folds of the rectum wall, which is caused by the circular muscles of the wall of the rectum. All right, circular muscles of the wall of the rectum. All right, or so that is a circular fold of muscle. But again, it is not merely what confined to the mucosa. That is not the case for it is not the case for what do we say, like I said, it's not the case for um for the that of the jejunum and then the duodenum. All right, it's different because for that they are actually confined to the mucosa of what? The bowel. Okay, for the jejunum, for the duodenum, but it's different from that of the rectum. Okay. Now, if you also come to look at the structure of the rectum itself, there is a gradual what we say the length is about 12 to 13 centimeters. Okay, about 12 to 13 centimeters. Okay, that's just it. And if you take a look at the um, rectum as we can see here, all right, let's compare to the other part of the large bowel. All right, you will see a clear difference. First off, on this large bowel, what you can appreciate is the fact that, let's look at three things. There are um, there are the peritoneum, all right. First, on this outer place that it covers what the surface of the rectum, okay. And when this peritoneum is peeled off, you can see the rectal muscle. I mean the muscles of the smooth muscles of what the colon, okay. The ascending, the second, the ascending column, the transverse column, and the descending column, the sigmoid column, ending at the level of the third sacral vertebra, okay, and then beyond which commence what the rectum at that same level where the sigmoid column ends. All right, something is very similar with all this. eh? The peritoneum, the ostration that you see, all right, the tinea coli, all right. Here clearly seen is what the tinea. There are three type of the tinea coli, which you would learn in the lecture on the bowel, okay. And then you could see the okay. Look at it. There are two anti-mesenteric, and then the one mesenteric and two anti-mesenteric tinea coli, all right. But again, when we look at the rectum, there is a gradual transition from the from the sigmoid column to the rectum, all right. And first, the peritoneum as well as the mesentery, all right. The mesentery is a structure that anchors the bowel into the posterior abdominal wall, okay. You don't have that in the rectum, all right. It's absent in the rectum. So the mesentery ends at the terminal point, but of what um the sigmoid column, all right. Also, as you can see, these are small out pocketing of what uh, 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 they are actually lymphoid this appendix epiploica, okay. You see them scattered in the throughout the length of the what large colon, except in the rectum is completely absent. Now the tinea coli also will completely we what we from the we change. It's a longitudinal band that transformed that change from being this longitudinal band to what is called the longitudinal muscles of the rectum, all right. The sorry my battery, the longitudinal muscles of the rectum, and you can see it. In fact, they appear to converge at the lateral part of the this is to form a longitudinal muscles, okay, of the rectum. And you can actually appreciate this also on a radio or radiographic image or film. But here um, you can see the numerous ostration that you see here. You may not be able to appreciate the tinea coli and all that, okay? But it's different from that what which you see on the rectum. And unless if you take an histologic image of this, yes, just the low power magnification to show the longitudinal what is it just to show just the longitudinal section of it. I'm sure you do that in histology. You can actually appreciate these goblet cells. I'm sure you know what the goblet cells is, right? Now we'll take a little bit a look at the anorectal what junction. All right, the anorectal junction. But so far, as we've been going, please let me just get a quick response from you. If you are following up with the lecture, please, I want to watch your response, please. Hope you can hear me very well. Yes, let me get a response from you. There are only 25 people left in this class. There are just 25 people left in this class. Hello. So far, so good. Are you following up? Only Joseph has responded. Are you following up, or is there any gray area or anything? As in, is it that you're not following up, or you're following up? Let me know if I'll go on with the lecture. Sorry, let me take this call. Hello. All right. Sorry, I was just on a call. An urgent call I have to take. And I think one person has just responded only that is following up. Why the other person say you can hear me? It's okay to hear me, but the point is, if it's not just hearing me, are we communicating? Are you really grabbing the message or the information as should be? Or probably when we release it, you watch or you read it later. Let me know which one, please. I only get one response, and that would not be enough for me. Okay, since I'm not getting any much feedback or feedback that is as encouraging, okay, 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 all right, all right. So I'll go back to the slide. All right, I actually do come back from time to time to see um, where we are. All right, so I'll go back to the slide and uh, uh, these few people that are actually coming up with their getting the slide, sending their matriculum. I thought we've passed that. Okay, I thought we've passed that. We've gone find the lecture, so I think I just want to believe that they are just joining us now. They are just joining us now, but it's okay. We will still move on. I actually wanted to have an encouraging number, but it's quite funny that I'm not getting what I should get. But so far, so good. I think we've been moving on. A few people who can understand, who can get me clear. We are really, really good to go. All right. So now the the mesorectum, okay. Sorry, not the mesorectum. Looking at the anorectal junction, okay. All right, the anorectal junction. Now, this image is clearly taken, all right. I think you can follow up, all right, and to describe what the anorectal junction. Now, if you follow up, if you remember our lecture on the pelvic wall, on the pelvic, okay, and then the pelvic floor, we actually deal extensively with the um, muscles that make up the pelvic diaphragm, the floor of the pelvic. And so basically there are two. We have the levator herniae, and then we also have the um, um, we also have the coccygeus, which is also called the ischiococcygious, okay? And then we also went further to different classify the levator herniae muscles into basically two: the pubo uh, puborectalis, sorry, rather the uh, pubococcygeus and then ischio-iliococcygeus muscles, okay? And we were able to define the origin. We said we also went further to define the functional parts, different functional parts, component of the pubococcygeus, for which um, the puborectalis that forms a sling around the rectum at the anorectal junction, eh, form a U shape muscle, and this is one of the pubis, one side of the pubis. There's the other side of the pubis. There's the right pubis, the left big bone, and there's the symphysis pubis, where these two pubic bone meet together. And you can appreciate the body, the posterior surface of the body of the pubis, seeing the part of the levator ani muscle, the one that the medial part that forms the puborectalis, that will form a U-shaped ring of muscle around the around the rectum, between at the junction between the rectum and the anus. You could see how closely connected it is with the deep external inner sphincter muscle. All right. Now, one thing you can appreciate here is the fact that the rectum, okay, make a downward and backward, what, downward and forward uh, move. All right, at the anterior, in the anterior, around um, the sling of puborectalis, and then exit by making also a downward, continue a downward, but this time backward move, forming an angle, okay, an angle known as or referred to as what, the anorectal angle. I'll explain so much about it on this image with a link on the slide I will send to you. All right, you could read more about that. Okay, that is what forming the what anorectal angle, and this the puborectalis will also merge the top of the external inner sphincter. You know, it has the deep, the superficial, and what, the subcutaneous part of this external inner sphincter. We'll do that. We'll have that in a separate lecture. All right, and also, if you also follow up, if you have follow up to this point, if you have follow up to this point, um, we said that the rectum, okay, at the commencement of the rectum, the mesentery, will what, will end, okay, with the lower border of the sigmoid colon. The circulations of the bowel that you see, of the large bowel you see, you don't. And we also say the mesentery, they don't have a mesentery. But there is a surgical terminology that is referred to as what, the the mesorectum is the that you see around what, the external wall of the rectum, okay, on the external surface aspect of the, and it is referred to as what, the mesorectum. And let's learn it is surgical. Yeah, it is surgical terminology. Looking at this, you could appreciate the fact that okay, vascular plane as well. All right, the vascular plane. All right, the vascular plane, because we will also look at another plane called the avascular plane that lies behind the uh, the mesorectal fascia, the connective tissue fascia that form the mesorectal. That's the mesorectal fascia, and it is between the avascular plane is lies between the mesorectal fascia and the uh, presacral or the anorectal fascia. All right, and we can see a collection of nerves forming a plexus around this, which is the hypogastric nerve. In this case, but as for the mesorectum, within this clearly the superior rectal artery and its branches. All right. Ordinarily, the superior rectal artery is a branch of the inferior mesenteric artery. On entering the inferior, on entering, divide into two main branch, two main lines, and each of them running on the rectum. Okay, within the mesorectal fascia. Okay, within the mesorectum, and they will give rise to their various branches that will supply the rectum. Virtually, it is the superior mesenteric artery that gives rise to the rectum. Also, as you can see within this mesorectum is what? The vein, which follows the artery, okay? The inferior, sorry, the superior rectal vein and the tributaries. But the superior rectal vein will also be a tributary to what? The inferior mesenteric. All right. We also have a lecture on the vessel of the wall of the vessel, the blood supply to the bowel. Okay, when you also appreciate the fact that it follows the embryologic origin, where the foregut structure are supplied by vessels from the, as in the, they are supplied generally from the branches of the celiac trunk. Okay, and guts, the mid guts are supplied by branches from the um, superior mesenteric artery, okay? While the iron guts will be supplied by branches from what? The inferior mesenteric artery, all right? That is also another lecture you look at, okay? They are all branches from the, all right, that's for the inferior mesenteric level of the L1 vertebra. That's not the case. That's not what we are discussing here. I hope you look at that. Also, as you can see within the is what the lymphatic vessels and their nodes. Okay, all right. Again, excision of the rectum in the case of rectal cancer. All these will also be removed alongside the rectum. Okay, they have to be removed alongside during surgical what operation that is done on the hernia. Like I said earlier on, I talked about the avascular plane, which is between the mesorectal fascia and the anorectal this thing, um, uh, uh, fascia. Okay, all right. You can actually appreciate the gastric nerve. Okay, and also seen here is what the middle rectal vein. It's not. It's I think only about 20% of an individual that, or about less than 20, or over. To not. No, it's true. It's not every individual has middle rectal artery. Okay, but for the individual, the 20% of individual that will have this middle rectal artery, it will only supply. We'll talk about that when we look at the blood supply or the vascular supply to the rectum. It will only supply the middle part of the what the rectum. Okay, all right. Now we'll just have to take a look, little bit of the okay, take a look at the peritoneum and the relations of the uh, rectum. But I also want to see if I hope I'm not too fast, please. A lot of us having just 20 people in this. I hope I'm not too fast. Please, a response from you. I only have 25 people left right now. I don't know why. For those following up, please respond on the comment section. Let me get your response from the comment section. I'm trying to wait for your comment at the comment section. The Ruth, Annele, Madera Christiana. Who is Madutidera Christiana? Soberi responded now, said that he can barely, she can, all right. How about others? Can they hear me clearly? Okay, I think for the ones keeping, okay, okay. Well, is everybody? This Joseph now saying that his life is keeping, all right. Odoko success. Are you also experiencing the same challenge? Is it? Okay. See, okay. I think I would. Okay, it's okay. No problem. One thing you can do is you can sometimes go and make it. I'll actually send a slide, a PowerPoint with a link attached to it. Okay, it's a it. I'll send it. I'll send it. All right. They have responded saying that their life is keeping, while one only okay 2 person has actually responded, and one said that the lecture is okay, no skipping. The guy who's the Odoko success has said lecture. Oh, is there any skipping? Odoko, you just responded not quite long ago. Please, is this skipping? You say no. I think if some people can. Now let us quickly look at the peritoneum. All right. I'll actually, when I take a little bit a look at take a bit look at the peritoneum, I'll still come back to see from the comment section if there's any challenges that we are having. All right. Now, I think when you do have a lecture on the abdomen, you will have peritoneum is one of the topic you would need to cover. Um, Let me also remind you that if you have the time, you can actually uh, quickly have a quick look at the peritoneum, all right? Because it's a very important thing, okay? Very important part of the abdomen, because most of the viscera are within the peritoneum, even though some are outside the peritoneum, and they are referred to as extraperitoneal or retroperitoneal organ, are those that are covered only on just one surface of the of the or only from one surface. For instance, the kidney is referred to as a retroperitoneal organ because and even part of the urethra and part of the urethra rather is also referred to as retroperitoneal. You could see that the peritoneum will only cover the anterior surface of that organ, and the posterior surface lies on the posterior abdominal wall. All right, clearly applied to. Okay, that's just that. Um, you see, the peritoneum will end uh, uh, at the level of it's at the level of the sacrum. Okay, and let's take a little bit look at the that of the male peritoneum. Okay, you can see the peritoneum. There's one similarity, the fact that the peritoneum will cover the upper third of the rectum also signifies that okay, that part of the rectum that is covered by peritoneum, okay, is a peritoneal organ. But in this case, you could actually appreciate the fact that it will only cover the anterior surface of that aspect. So the upper third of the rectum will be referred to as a retroperitoneal what? Organ. All right, the upper third. So it will end at what? The level of what? It will end at, if you check this, okay, we have the, or if you check this the third, second, and then the third, fourth, fifth sacrum, the fifth sacrum, sacral vertebra, you could see that the peritoneum end at that place, okay? And at that level, it will take a forward turn towards the anterior aspect of what on the superior surface of the bladder. Okay, for the male, all right, you see it's passing to take an anterior turn on the at this level to run on the superior surface of the bladder. Okay, and a recess or what is called pouch will be produced. Okay, this pouch is a dependent pouch, okay, where fluid will gravitate downward, okay, intraperitoneal fluid will gravitate downward in the standing position, all right? But again, for the sake of this lecture, you see it taking a forward turn, okay, all right, and this eh, is also called the what we can refer to as what the recto-uterine pouch. It's anatomical. You can clearly see between what sorry, recto vesica. Okay, the vesica is referring to what the bladder. All right, so you can see this this pouch is between what the rectum and the bladder. So it's called the recto vesica pouch. Okay, for the female, it's the same thing. All right, but the difference is that because the relation of the rectum in male is the bladder, which is one of the anterior relation is the bladder, the upper part of the what, the seminal vesicle, as well as what the ductus difference or the vas difference. Okay, and for female is quite different. Okay, here we have the uterus, okay, and then we have the bladder in front of the uterus, okay. So the posterior relation of the anterior relation of the rectum is what, the uterus, okay, and the upper part of the vagina, as you can see here, and the cervix, okay. So this relation, okay, you can clearly see how the peritoneum take a forward turn to run on the on the surface of the uterus, okay, and then come again to run, okay, to take a forward turn, okay, also to run on the bladder. So you have two recesses, okay, pouch, all right. The one between the rectum and the uterus, okay, is called it's called the recto-uterine pouch, and that between the same peritoneum between the uterus and the bladder is called what, uh, vesico-uterine pouch. Okay, but most of the time we usually look describe this because of fluid, especially in radiology or imaging modality. For instance, the ultrasound scan, they usually report maybe once there is a, say intraperitoneal fluid will gravitate down to this part which is dependent, is a dependent area. And when the fluid is physiological actually, but when it's merged, the sonographer would also clinically will see in most cases when it is merged, it usually correspond to disease in the pelvis or what we call pelvic inflammatory diseases. Okay, all right, but we'll continue. So you see how the peritoneum is reflected from the anterior surface of the rectum to the take it forward on towards the uterus. Okay, for the now from this we can define the relation. On the upper part you can see we have the, but you have the, for the female we have the uterus. Okay, for this part the lower pole of the uterus and the upper part of the vagina. All right, at the fornixes you can see the cervix is projecting into what uh, the vagina fornix. Okay, so this is the relation. All right, then on the other part of um, um, uh, the rectum, you can also see the vagina. All right, relating to what the throughout the length of the rectum is related to the vagina anteriorly. All right, and also just um, just that for the male, you have, like we mentioned earlier, the bladder, the superior, the base of the bladder. Okay, the upper part of the base of the bladder, all right, will be related to the peritoneum. All right, sorry, let me try to calm this noise first. Let me try to calm this noise. I will mute it briefly. Sorry, I hope you can hear me, please. Please, for those who can hear me, I can only see 26 people in this class. There are only 26 people in the class. I also don't. I also want to be sure that I'm not communicating to myself. Is there communication, please? Are we actually communicating? Yes. Let me get a response from you. There are only 23 people. Honestly, the class is not encouraging. We are communicating. At this point, I hope you can really, really understand me. Okay. Well, if you say anterior to the rectal vesical part, you actually, like we said earlier, you see the uppermost part of the base of the bladder. Of course, the rest part of the base of the bladder down to the infralateral surface of the bladder. Okay, sorry, just the uppermost part of the base of the bladder, and then the seminal vesicle, all right? And I think the seminal vesicle, all right? Then at the level, or if you go down below the level of the pouch or below, at the end of the peritoneum, you see the rest part of the base of the bladder, seminal vesicle. Also, the prostate in male is also related to what the uh, even the end of the ureter and the vas difference can also be described as a relation or and also be referred to as the anterior or the relation of what the rectum. All right. And then if you look between the rectum, there will be a condensation of what? Of a fascia which form what is called the rectal genital septum, or we can refer to as the rectovascular fascia of the novelius. I hope you can see that. I hope you can see that in the. Uh, I hope you can see. I hope you can see that on this thing, the Donovilia, okay, or it's called the what? It's called the recto what? Rectogenital septum. All right. All right. I think at this point I'll quickly go on to the blood supply of the rectum, the blood supply or the vascular supply. All right. I think time is just far spent, so I actually want to rush this part of it. All right, and then I think I think I made mention of the. Take her away now. Take her away, please. Hello. Um, please. At any point in time, if you cannot hear me, let me say the network is bad. There are only 18 people. Well, for those, if from my own end, I will actually listen to the video again. I would actually appreciate if you go back and watch the video if you have time. All right. If you have the time, you can watch the video. The lecture is too. I think well, time is fast spent. I will just quickly enter the blood supply, and I won't say much because I just know there are links there. But at least from this image, you can appreciate here is the abdominal aorta. Ending at the level of the third lumbar vertebra, it will bifurcate, okay, to end and bifurcate into what is called what the common iliac vessel. In this case, we are looking at the artery, all right, and the each both right and left, okay, will further divide into what the internal and external iliac artery. All right. First off, we have the inferior mesenteric artery, which is a branch of what the uh, abdominal aorta. All right. It will give the most of the supply, most of the vascular supply to the rectum comes from the uh, sup- uh, the superior rectal artery, the inferior superior rectal, which is a branch of the inferior mesenteric artery. All right. Like I say, I think about 20% or so for few individuals we have what have a middle rectal artery, which is a branch coming from the internal iliac artery. All right. When it happens, it will only give supply to the uh, uh, it will only give a supply to the middle part of the rectum at the level of the ampulla. Okay. And then you also have the inferior rectal artery, okay, and then you could see that the vein for the superior rectal vein will follow the corresponding artery, all right. It's a correct vein to the artery, so it will drain to the inferior mesenteric what vein that will join the inferior in turn join um, the splenic vein, all right, the splenic vein to form what. Okay, then the for the middle rectal vein, it will drain along the both the middle and inferior rectal vein will follow what the corresponding artery. We say it's a corresponding vein to the artery, okay, and then it will drain to the internal iliac, and then and so on and so forth. It follows. Now, this is very, very important because when we talk about what is called pile or what pile or hemorrhoid, okay, in hemorrhoid, it is as a result of Annabelle. How are you? I will say, I'm in a lecture, please. Go and play. So it's the dilatation of this the superior rectal vein will give rise to what is called what the within the mucosa. When we look at hemorrhoid, okay, we will look at the component of the hemorrhoid. It contains a mucosa, okay, of the rectum, okay, the rectum, okay, and it will also contain what the vein which are dilated, okay, at the terminal part of the superior rectal vein, okay. And now we could see the lymphatic vessels, okay. Actually uh, uh, they are actually um, uh, okay, actually divided into various levels. We have three levels, okay. But for now, what you can appreciate, what we could see here is that the fact that you have they are marked, the labeled A, B, and C, and you see the path through which they drain, okay. This will drain towards the origin of the inferior mesenteric nodes, okay. It will follow the inferior mesenteric artery, or rather, while uh, uh, this will follow what the nodes at the origin of the sigmoid branches, okay. They follow the artery. These are the origin of the sigmoid branch. Follow the superior rectal. Just follow this part, all right. And that is the upper and middle third of the this thing. While the lower third of the rectum will join the nodes to that with that of the anus, okay. It just I don't think we would be able to talk so much about it. Here is just to show you, okay, just a further view, and you could see that this ones will receive the parasecond node. This is the level 1, level 2, and level 3, okay, parts. The level 3, the level 1, both the level 2, 1 and sorry, most of the level 1 will empty into what the common iliac node, and that of the level um, it's part of the most of the level 2 and a bit part of at the level 3 we empty into what the internal iliac node, and so on and so forth. Some we have to drain to the horizontal set of nodes on the superficial, but this actually is to the anus, okay. For the rectum, you follow this path, eh? And then the innervation. I think I'm actually concerned about the time. Time is fast spent. When I send this slide to you, I will expect you to look for that. But when you look at it and when you watch the video, when you read the slide, if you ask, I'm open to any questions and response from you after looking at the slide. Or peradventure, I want to see the few people who so far since the beginning of the lecture have been following up. So far so good. Is there any question? Is there any question? Okay. In the absence of any question, I also want to assume that you guys have followed up, or you've understood, or you didn't understand at all. But um I think I will have to, because of time is fast paced, I have to call this lecture to an end. Once more, thank you for joining the class. Our next lecture will be uh, our next lecture will have to be on. Okay, look at, you can see. Sorry, you can see this imaging. Yeah, they do double variant, double contrast imaging showing the rectum. Okay, and we can see some in this place. You can see a central ring of rectum that is formed. But in this case, these are actually pathological because you can just see it. But again, when I have a if you have gone through the slide that I will share, we will be able to get feedback from you. All right. In the absence of any question, we call this lecture to an end. Once again, thank you very much. The last 15 people that okay, so many people were not here. Network is not the issue because if there is network, someone would have been able to join at the beginning. Good luck.